Needle injuries, which could be a suture needle injury or a hypodermic needle injuries. We'll talk about the risk of HIV transmission, hepatitis B and SCV transmission among healthcare professionals. These kind of injuries are mostly seen in medical students, nurses and surgery residents. According to a study, 83% reported that they had sustained a needlestick injury, with an average of 7 injuries during residency period. The contributing factors are a high exposure risk from these injuries. In an emergency situation, they are often feeling rushed in due to a high caseload. They are obviously inexperienced and fatigued all the time. Once a medical professional sustains a needlestick injury, these can have a long-term psychological effect like anxiety, depression, insomnia, anorexia, and a career regret. Most of these injuries are underreported. Trainees over a period of time became desensitized with each event or may be embarrassed to report about it. Other studies have observed that most surgeons substantially underestimate seroconversion risk with every exposure. Now, most of these injuries are self-inflicted injuries, could be due to syringe needles injuries in 36% of the cases or suture needle injuries in 18% of the cases. Approximately 60% of them occurs while suturing muscle and deep fascia, while 41% occurs while suturing skin and other soft tissue. According to a study, the HIV transmission risk is about 0.3% or 3 out of every 1,000 healthcare workers. The risk of transmission also depends upon the quantity of the blood struck with a large bore needle, the viral titer of infected fluid, which may be about 10,000 fold depending on the clinical stage of the patient's disease. It also depends on the depth of the penetration. In case of any exposure to HIV infected blood, to be effective, the post-exposure prophylaxis must begin within 72 hours of exposure. The commonly referenced study of 1989 estimates the risk of HIV transmission to be about 0.32%, but this 3 out of 1,000 estimate pertained more to untreated source patient with late-stage symptomatic disease, which was the more likely scenario in 1989 than to estimates based purely on needlestick injury alone. A new meta-analysis conducted in 2006 estimates the HIV risk more along the lines of 0.13% if the needlestick injury was the only risk factor. The seroconversion risk for HIV is about 0.1 to 0.3%, for hepatitis C virus 3 to 10%, and is the highest among the three for hepatitis B from 7 to 30%. In case of hepatitis B exposure, if the patient is hepatitis B positive, the recipient's serology must be assessed. If the post-vaccination anti-HBs levels are high, greater than 10, this is known to be productive and there is no need for further treatment and a booster shot is not recommended. However, if the post-vaccination titers are low, the health worker should be administered hepatitis B immunoglobulin. For clinicians who have not completed the vaccine series, both hepatitis B immunoglobulin and the vaccine should be given as soon as possible within 24 hours of exposure. Unlike hepatitis B virus infection, where less than 6% of adults develop a chronic infection, with hepatitis C, more than 75% of adults will develop a chronic infection. About 3/4 of these patients will develop acute liver disease, and of these, about 20% will go on to develop end-stage liver disease or cirrhosis. In case of SCV exposure, immediate testing for anti-SCV antibodies and confirmatory immunoassays for SCV RNA should be done. Repeat testing at 6 weeks, 3 months and 6 months is recommended in non-SCV exposure in order to account for the lag between infection and seroconversion. Treatment for seroconversion usually consists of 24 to 48 weeks of interferon therapy with or without ribavirin. One of the most important determinant of blood contamination is the gloving. Double gloving can reduce the risk of blood contamination by a factor of 7 to 8.